عالم الغيب والشهادة هو الرحمن الرحيم هو الله الذي لا إله إلا هو الملك القدوس السلام المؤمن المهيمن العزيز الجبار المتكبر سبحان الله عما يشركون هو الله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم صدق الله العظيم.
Jazakallah Ahmed Harun. Now I'll request Vice Chancellor of Rawalpindi Medical University to come and have a welcome remarks for the attendees of today's sessions and students.
Namtahu nusalli ala rasulihil kareem. Bismillah ar-Rahman ar-Rahim. Worthy Professor Naheed Usmani, Dr. Shahid Rafiq, delegates from America, APPNA, Higher Education Commissions, faculty of Rawalpindi Medical Universities, principals and vice chancellors of further colleges and university, our primary physicians, friends, national delegates, and my very dear students. Very warm welcome on the second day, and I hope you enjoyed the meeting yesterday. Thank you very much. I understand that you may not be familiar with the lot of terms going on, particularly our students, and may not take the whole things in that context which are understood by the front rows. But it is a great opportunity to understand and get well versed with the international scenario, international narratives. As I said yesterday, disease and knowledge has no boundaries. Corona doesn't have to take any visa to travel in 72 countries. It is the awareness. It is the communications. The world has become the global village. So the Rawalpindi Medical University is really honored, and the faculty of Rawalpindi Medical University, and you being the future professors and faculty, getting this opportunity of interacting with the people who are working in the first worlds, and they are known for their contribution in medical education and training, research, and clinically good practices. So I think I appreciate the whole organizing team who give you and me the opportunity to interact with this class, the world-class leaders in the medical profession, to interact. It is, if you don't understand, even their body language, their way of expression, their punctuality, their good ethics. So you don't learn only from the books. You learn from the behavior and approach and body language of the professionals. I think we are lucky that we're getting all this free of cost. And I'm grateful to the APPNA and particularly our alumni, Dr. Shahid Rafiq, Dr. Zahid Rafiq, Dr. Nadeem, who are sacrificing their time, their family commitment, their money to bring and raise the status of their alma mater, which is Rawalpindi Medical University. Sir, I'm thankful to you. And finally, this is not only you and me are learning from them. Look at the noble mission, the noble thinking they have. Ultimately, they want to establish a specialty of family medicine, which will benefit the poor patient of this country. They are struggling to develop a system of integrated healthcare where the primary physicians is the key or the backbone. So look at this spirit. So ultimately, madam, you and your team is not be rewarded here, but they are rewarded the world hereafter, because you are working. अल्लाह ताला की मखलूक के लिए आप काम कर रहे हैं, एक बीमार आदमी के लिए एक सिस्टम इवॉल्व करने के लिए आप काम कर रहे हैं। आप एक जो इस मुल्क में एक कमी है उसको दूर करने के लिए, जो पेशेंट केयर है उसको अपलिफ्ट करने के लिए काम कर रहे हैं। तो यू आर रिवॉर्ड, yesterday somebody said that 5 are respect, recognition, reward and something else. So it is not the RMU, it is not the Higher Education Commission, it is not the federal government, it is beyond these boundaries, and that is Allah Ta'ala Subhanahu wa Ta'ala. So Sir Dr. Jaleel, the mission you have, it is not a smaller vision where you expect only from RMU or Higher Education Commission. You are working for a bigger cause, and this bigger cause is for the mankind. And I'm sure this is going to succeed because the God is behind this. So you as a students will be remembered being the pioneers to start this program and to support this noble mission. And Rawalpindi Medical University is always carrying this flag for all these noble missions. I thank you once again and welcome you once again on the second day of conference. Thank you very much.
Thank you, Dr. Umar. Now I will invite the moderator for the first session for the healthcare systems and role of technology. The moderator is Dr. Zahid Rafiq, and he will invite the speakers and the panelists and chair. Thank you.
Thank you. Assalamu alaikum. My name is Zahid Rafiq. I'm family doc from Canada, Calgary. Today, this working session is number 3 working session for this conference. And it's a very important session, healthcare systems and role of technology. In Western world, in North America, we are having the benefit of technology and implementing of technology in healthcare systems. So that's what we're going to discuss in this session. So our chair for this session is Major General Salim Ahmed Khan, Halal Imtiaz. He is principal of Army Medical College. General Sahab graduated in 1983 from Army Medical College. In 1995, he got his fellowship in hematology, and in recognition for his academic excellence and contribution to health services, he was also awarded fellowship from Royal College in 2015. Presently, he is holding the office of Principal of Army Medical College. He is also Dean Faculty of Hematology from CPSA, and also he is Dean Basic Sciences, National University of Medical Sciences, NUMS. Please welcome Major General Salim Ahmed Khan. Thank you, sir. So we have 2 panelists for this session. First panelist is Professor Musaratul Husnain Shah. He's MBBS, DSS, DCPS, SPE, MHPE, PhD scholars. Half of them I don't know what they stand for. So he's Professor of Medical Education, Rashid Latif Medical College, Lahore. He's Visiting Professor of Medical Education, University of Health Sciences, Lahore. Please welcome Professor Masroor Hussain Shah. I don't. He's coming? Okay. Let me introduce our next panelist. It's Professor Mustafa Kamal Pasha. Professor Saab is a Vice Chancellor of National Medical University, Multan, and has earned a reputation of being one of the best surgeons of Pakistan. His contribution in modern research related to laparoscopy surgery, introducing innovative pre-operation, post-operation techniques, and in transferring knowledge to thousands of undergraduate and postgraduate students and doctors over the last 3 decades remains exemplary. He started off as a lecturer at National Medical College. After completing his academic years, he won about 18 gold medals and silver medals in various years. He was the best graduate of the university. He served as Dean of Surgery at National Medical College. And when National Medical College became university in 2017, he was picked up as being first Vice Chancellor, founding Vice Chancellor of the university. Please welcome Professor Saab, Professor Mustafa. Thank you, sir. So I think let me introduce, let's wait, our first panelist will join in as soon as he comes in. So for this session, the way it works is we have our panelists and we have 2 speakers. So speakers will they will deliver their talks first, and then we'll open the floor for Q&A. And this is your session, your learning workshop. We want it to be interactive. Your questions and answers will be answered here, and if you can't answer some questions, we'll keep it for later, addressing them later. So let me introduce our first speaker. So as you know, the topic is healthcare system and role of technology. So first speaker is Dr. Fizza S. Gilani from Brown University, USA. Dr. Fizza Gilani is a research track faculty member at Alpert Medical School of Brown University, Providence, Rhode Island, USA. Dr. Gilani completed her PhD in econometrics from Boston University, Massachusetts, USA. Her career has involved from econometrics to health economics to HIV/AIDS epidemiologist to her current focus on healthcare informatics, quality improvement, and public health. So he has lots of contributions, lots of papers, lots of research, has all the work, most work is in HIV and epidemiology. Is about more than half a page for her contribution in the field of epidemiology. Let me invite her, Dr. Gilani, please come on the stage, please, for your presentation.
Assalamu alaikum, everyone. I have to wait for the slides. So I have been told to talk about healthcare technologies and insurances and healthcare systems in USA. And to me, this is darya ko kuze mein band karne ki baat hai. And I will try my best in the next 10 minutes to do so. Yeah, no. Yeah, there. Yeah, hand mic will do that. So I have to position myself. So I will not do the backward from any side. Yeah. Isko band kar. Can all of you see the slides? So I'll start with healthcare systems. In any healthcare system, there are 4 different levels. Number 1 is the patient, and patient is individual patient. Number 2 is the caretaker team. Caretaker team includes doctors and all healthcare related personnel, and of course patient's family. We always include them as in the caretaker team. Number 3 is institution. That is clinic, hospital, nursing home, or any institution related to healthcare. And number 4 is the government organizations, and these are the regulatory healthcare organizations. So I will start with 4 models of healthcare. So in literature, there are 4 different models. The first one is the beverage model. In this model, the healthcare is run by government and taxes are paid by the public to cover the cost of running the hospitals. Everyone has to pay the same amount of taxes irrespective of level of usage. So this is the model number 1, and many countries adopt these models. Second model is the Bismarck model. In this model, the healthcare costs are usually covered by individuals and their employers. Insurance has to be offered to everyone, and insurance companies can't try to make a profit. Hospitals are run by individuals instead of the government, but since the government still has a big stake in the industry, costs stay low. And this model costs individuals more than the beverage model, but there's also more freedom involved. Third model is the National Health Insurance model. This model has many privatized practices like the Bismarck model, but it's paid for by the government like the beverage model. The good news is the government is usually able to keep costs low for patients, but the bad news is that they can choose which medical procedure they will pay for. Also, individuals can end up waiting a long time to be treated. But still, many countries, they adopt this model. The fourth model is out-of-pocket model, and many countries follow this model. Basically, everything is up to individuals. All healthcare practices are privatized and are allowed to charge however much they would like to, and the sick and injured are required to come up with enough money to pay for the bill themselves. This is good for the people who are well off, but it's not good for the poor people. So now, out of all these 4 models, how USA works. In USA, we have all these 4 models at the same time. And I'm not sure how many of you are familiar with the USA healthcare systems. Under the beverage model, we have 2 different systems, veteran affairs systems and military healthcare system. They come under this beverage model. In Bismarck, we have public health insurances paid through employers, HMO and PPOs. And national health insurance is Medicare and Medicaid. And out-of-pocket is all uninsured or self-pay people. So these models 4 together, they work in USA. But in different countries, we have different combinations of these models. So now, if you look at these, like most common plans in USA are Medicare and Medicaid, and this is the national health insurance. Under Medicare, Medicare is available to all people age 65 and above, and the people of any age who have any kidney or failure or long-term kidney disease, and people who are currently disabled. This is the Medicare eligibility. And in Medicaid, all low income. And these are pregnant women, children under 19, people who are 65 or above, and people who are blind, and people who are disabled, and who need nursing home. So all these people, they can get free health care from government, And this is our Medicare or Medicaid, both system. In the public health insurances, we have two different models, HMO and PPOs. I will not go in detail of these because we did not define them, but generally HMO are health maintenance organizations and PPO are the preferred physicians organization, preferred provider organizations. There are small systems. HMO is more cheaper, but it is more restricted, and PPO is you pay more, but you have more options under this. You can select the doctors wherever, it's like in Pakistan, if you have PPO, you can go to any specialist without any referral system. But in HMO, you need to have referrals from your primary care. So now I will come to healthcare technology. Okay, sorry, I think some slides are. Okay, so healthcare technology. In USA, the government in 2004 introduced a new bill that was called High-Tech Act. Under that bill, all the private doctors and all clinics and hospitals, they needed to adopt the EMRs or EHR technologies, and they were asked to adopt these technologies by 2015. And if they do it before 2015, they will get the different incentives from government. But if they don't do it, they will start having penalties. So that's why the whole system moved towards adaptation of EHR. EHR is electronic health records. And many hospitals, we were at around 8% of the hospitals who were using EHR in 2008. But after this bill was more restricted, we have around 80% of the public hospitals who are on EHR system. So that act worked and is very successful now. Even all the private medical doctors, they are obliged, legally they are forced to use the EHRs. So personally, I will tell you the experience of two different models which I am very involved in. Number one, I am a part of a teaching hospitals. We have a large HIV clinic, and it's a part of Brown University Teaching Hospital, and we have 23 HIV specialists. We have 5 nurses, 3 social workers, and many physician assistants, and around 5 or 6 MAs. And we adopted EHR in 2011. And the beauty of that is the whole group, they can just see each other notes, they can, like a referral system, everything is streamlined since we adopted the EHR. And this is the largest EHR in USA, that is APPNA. And our doctors and everyone is very happy with that. If you see, can you see the slides? Read the slides? And I can't do this from here. So in our system, we have a very intensive research program. We have teaching options, many ID fellows. We have residents, researchers, clinicians, and they all use the same EHR system. So the communication between the group is very easy after EHRs. And our clinic in this, after EHR, is a perfect example of HIV care coordination and between different organizations with our own hospital, within own hospital and within the state. And my second is, this is an independent primary care clinic. It has 3 sites. And this practice was started in 2009 and acquired electronic health records in the same period. And this practice is part of Primary Care Association of Rhode Island. This Primary Care Association of Rhode Island, they help these individual clinics to adopt the EHRs. And they also help these clinics to get different services, which are the case managers and counseling services through this clinic, and we have so many, like in this clinic is like very active in different reportings, different government programs, including meaningful use, patient-centered medical home, and PTS reporting. So, but this is all possible because of electronic health records. And without electronic health record, this was like nothing can be done. And especially in terms of government obligations, we have to fill out all of this. If we don't have electronic health records, it will be by hand. So this is, and this clinic is also participating in state level health information exchange, where if you feel the patient information is available in different hospitals, whatever is done in the clinic. So these two different models, teaching hospital and a primary care, they both are using the same EHR and very successfully using and improving the patient lives. So now the advantages of electronic health records for patients. They can get the appointments on improving timeliness. They can just log on to their programs and their portals and make the appointments. And they can just manage, if you want to cancel the appointment, you can just log in and cancel or reschedule. And then healthcare data tracking by patients. Patients have portals available within this EHR. If I want to see my lab reports, I can just log into my account and see all the lab availables or history of labs. Then reminders, like, let's say if I have an appointment, I can get the reminder on my phone through this system. And the history available is all of patient history is available in last like 10-15 years. However, the patient is going to that clinic. So this is the patient level benefits. So benefits of EHS system for the care team, access to critical care and administrative information, and permanent updates about the patient conditions, and decision support system, reduction of errors. It means if a physician is prescribing something, the system will check that patient's previous medications, and it will give you the alerts that the patient is on that medication, and the new medication can have the side effects or will not work with the old one. And we have medical and social histories available in the system. And then group management is very important. We have improved care coordination, easy reference system, and patient is given a kind of discharge summary or the visit summary at the end. If a patient wants to go to any other doctor, he can just get the printed summaries and use that as means he doesn't have to describe his own conditions to the second doctor. So the summaries are very useful for patients. They don't have to do anything else for this. So EHR benefits for the organization. This is very important too, the streamlined billing processes, because healthcare billing is very complicated in USA. But because of EHR, all the diagnoses and procedure codes are in the system, so it's very easy to build the processes. Then reduce storage space requirements and easy to design new QI processes because of information is there. And streamline managerial processes and streamline employee education and training process. All these are cited benefits for EHR by different organizations and their CMOs. So political and economic benefits of EHR. This is a very important issue. We have improved quality of life, healthy workforce, disease surveillance available, decreased health disparities, and increased employment. These are the benefits of healthcare technologies at political and economic level. So disadvantage are it's a very expensive investment, need careful long-term planning, need to create new departments in the organization, physicians, staff and employees hesitation of adopting new technologies, and not so skilled labor force available. But in my view, this is the future, and this is a good time to actually advance the labor force, teach them new skills, and teach them the upcoming challenges of life. So in summary, EHRs are a major step toward a transformed healthcare system. These are the future of healthcare industry. These systems are aimed at increasing efficiency, safety, communication, collaboration across health providers, overall patient satisfaction, patient health outcomes, and population level health outcomes, and healthy workforce. So healthcare technologies can play a really great roles in any nation, improving its patient health outcomes and healthy workforce. So this is what's happening in USA, and I will leave up to our panelists to decide what we do here and to come up with the new policies, what can be done. And thank you, APPNA Merit and Conference Organization.
Thank you, Dr. Fiza Gilani, for your enlightening talk. So our next talk is embracing the digital revolution in learning, e-learning. And I will invite Dr. Danish Bhatti from University of Nebraska Medical Center, USA. And he's APPNA Merit's co-chair. He's our young, enthusiastic, mashallah. He's done so well for this workshop. He prepared us for last 2-3 months. His hard work is exemplary, and he kept us on our toes for this organization, for this conference. So let me introduce him. Dr. Danish Bhatti is a movement disorder neurologist and teaches physicians internationally. Dr. Bhatti has directed an online fellowship for movement disorder since 2017. He's a founding director of International Neurology Program at University of Nebraska Medical University. He received International Best Teachers Awards from Pakistan Society of Neurology Pakistan, and also he received an award on Impact in Education for Innovation Practices Award from Campus-Wide Award at UNMC. Dr. Bhatti participates in many multi-center trials, and also he works at UNO, including pharmacology and biometrics trials and things. Please welcome Danish Bhatti.
All right, thank you. So I'll try to convince you that our new technological way of learning are equally good and maybe better in some ways than the traditional method of learning. The traditional method of learning is what we call a seminar. Seminar is when I stand here and I tell you about something for half an hour, let's say subthalamic nucleus and its role in management of Parkinson's disease, which is my interest. And then I expect you to remember everything afterwards. That's the traditional method of learning. But I think we have enough technology to now make it so that the learning is flexible, learning is more effective, and we can measure how good or bad the learning is. So let's look at what's going on in the field of e-learning. So these are the top e-learning statistics from 2019. The global e-learning market has become $107 billion by 2015. That's how much money is being made just by online courses. And online courses are considered normal for people who do jobs like on freelancing. So if you hire someone to edit your podcast, edit your video, build like a monogram or logo for you, and if his resume says that he has done online courses to train for that, that's accepted as normal, and that's just fine. He doesn't have to go to a school to get a diploma or a degree to do those kind of jobs. So a lot of jobs are now accepting an online learning method. 77% of US companies are using online learning for on-job training. So you hired someone with a basic training that they had, but you want them to do a very specific job. So you do some additional modular training. So I, as a physician, has to do annual modular training requirement at University of Nebraska. That includes the University of Nebraska's policy on infection control, on disease modification, how to respond to a threat. If there is someone, an active shooter on the campus, what am I supposed to do? If there's a fire alarm, if there's a thunderstorm, what am I supposed to do? All of that is taught to me through these online modules by my university. So I do an annual about 10 to 15 hours of online training every year to keep updates with the new policy. And so US government is also spending all that money on it. 43% of US college students find the digital learning very helpful, very useful. So it's becoming a very norm there. We have an online learning system implemented at University of Nebraska for the last 20 years. We just updated it 2 years ago to Canvas. 49% of the students are using e-learning. 67% of organizations are offering mobile learning. So if I deploy a test for my medical students who are rotating with me or my residents, they can actually just do it on their cell phones. While they're waiting in the resident room or they're in a cafe or wherever, they don't have to do a paper test anymore, and they can do it wherever they want and whenever they want. So e-learning is becoming extremely successful and extremely common in United States. So what is the cost of e-learning? How expensive it is? These are the US costs, as you can see, that $160,000 per year and $260,000 for initial setting up. Now, why do I put this money information there? It's because to realize how important somebody thinks it is, you can see it in the dollar amount. If a university in the United States is willing to spend $259,000 to establish a learning modular system, that tells you the university highly believes in it. And if the thing is really not liked by a lot, it does not have much of a demand, the numbers would have gone down. The numbers have gone up. You can see that these systems have become so expensive because they are so sought after. People want to spend that money in the United States because they think it's worth it. There is value in doing it. And of course, we don't have to spend that kind of money in Pakistan. We can build our own, definitely much more cheaper and affordably. So what is the biggest challenge in education that the online learning is trying to solve? Why online learning have become so effective? Is because of this revolution that started 30, 40 years ago, which is called evidence-based principles of learning. How do someone learn? What are the evidence of it? And how can you make it more effective? So initially the challenge was that how do we make every teacher very effective, right? There are some great teachers that everybody loves. People go to their lecture and they understand everything, they remember everything. And then there are other teachers where you go in and you come out and you're not any better. You still have to go back and read the books and figure out, okay, what was it being taught and how am I going to remember it? So the United States started thinking about how can we make every experience great, that any teacher that you walk in, do you get the same amount of effective learning, where that when you walk out of the room an hour later, you know the things that were being taught and you remembered them. And what they found was, in order to answer that question, you have to first answer, how do students learn? What are the rules or principles or evidence that decides that how the learning happens? So there are these 7 evidence-based principles that are considered the guidelines of learning for all institutions in the United States, including medical universities. And I picked the 3 in there. So number 2 that I picked was the way the students organize their knowledge, how they classify them, how they schedule them, how they tabulate them, is how they will apply that knowledge. The way they remember the classifications is how they will apply it. Another one that they said is the goal-directed, targeted feedback is important for learning. So let me explain that a little bit. In the old days, it used to be that you say that if you want to learn something, you have to do enough of it. So I went to my teacher once and I said, I want to learn fundoscopic examination. I want to see behind the eye in the retina and I'm not really good about it. And his recommendation was, well, go do 100 fundoscopies and then you will know how to do it, right? That was the concept. But what we have figured out is that it doesn't matter how many times you do fundoscopy. What matters is that every time that you do it, somebody can tell you what mistake you made. So it's the targeted feedback. And if you do targeted feedback, actually you can teach fundoscopies in 5 to 7 attempts. In 5 to 7 practices of fundoscopy are enough to teach, and you don't need 100, and 100 is only needed when you're giving yourself a feedback that this is how, oh, I did this wrong, or I did that wrong, and you may not figure it out for the 10 tries, or 15 tries, or even 20 tries. So the targeted feedback is the key to solve the issue. So quantity is not that important in learning. Quality is important in what feedback you're getting and who is pointing out the mistakes that you were making, which is necessary. So this is an example, right? This is a WhatsApp message somebody shared. So someone was prescribed a medication and he opened up and he tried taking it. He says, how do you take it? It says 1 teaspoon or one of it, but how should I mix it with water? And the answer was that you're eating the cotton above the pills, above the drug, and that's just the cotton. So if you don't give the right information, you just dispense the bottle to someone and say, take 1 spoon every day, and he opens it up and it's just cotton on the top. He starts eating it. That means that your instructions were wrong. It's not the patient's fault. It's the physician's fault of not giving the right instruction to the patient, right? And that's the problem we have in teaching. So if we teach how we were teaching all the time, we'll get the same results we have gotten every time, which were not bad, to be honest. I'm standing here from the old methods of learning, but I know it can be better. I know that rather than having 10 students great in the class, we can have 50 students great in the class if we can improve the methods of teaching that we have. So what is my examples and my interest? So I build these online courses which are blended with face-to-face learning. The online courses allow the students to take assignments on their time, to go back and review the lectures, to go back and take quizzes. And that gives me information in more details with these details analysis in terms of graphs and plots on how much time someone is spending. I can actually see that if someone watched a lecture, then there was a part of the lecture that was re-watched a few times. Now I know that that particular part of the lecture was a sticking point for the student. I can also see that how much time a student spent on a specific question. So if I ask them 10 questions to answer on MCQs, I can tell that this question number 7, everybody's getting wrong and everybody's spending 5 times more time on answering to that question. It may be that I didn't write the question right. Maybe I'm not asking them what I need to ask in terms of assessing what they need to answer. So this detailed analysis helps me give a targeted feedback. It allows more organization of the knowledge that the student needs in terms of learning, and then it allows the repetition that is required and a flexibility of self-learning. So I also do education online, and the power is in scalability. So I have a YouTube channel where I post videos. It started with this first video on the top, which was called a 5-minute neuroexamination. And in 14 months, we have reached 1.5 million views of a 5-minute neuroexamination. That shows you that how scalable this information is, that you can teach the right information by these kind of platforms to a very large number of students. So what I've done in Pakistan so far is that we started an online mini fellowship for a component of neurology called movement disorders. Movement disorders assessment of Parkinson's disease, of tremors, of chorea, dystonia, ataxia, balance problem. Very complicated subject, very hard to teach. It does not exist in Pakistan as a separate field or specialty. This is what I have been trained in. I have a fellowship in it, and I'm the program director for our own fellowship, associate program director. So I decided to build a program of 6 months to teach the neurology graduates of Pakistan extra additional training on this field of neurology because they did not have fellowship trained teachers available locally. And it has been highly successful. We have graduated 3 classes so far where we take neurologists, recent graduates, we teach them these additional skills by showing them videos, by giving them targeted feedback. So the fellows in this course, they do these video assessment, they write their plan, and then I give them targeted feedback on what they're missing on each of this video, what component is missing, and then the structure is organized for them, and then it has the flexibility of doing it any time of the day, at any speed that they want. We show at least a 30% improvement in their performance at the beginning, from the beginning towards the very end, and a certificate is given from University of Nebraska. I am also building many such courses. Most of these courses I'm building for my own residents and trainees. You know, we have 18 courses, short courses for our residents as they go through the training of neurology that they have to take as they're doing their training in addition to seeing their patients. So not just face-to-face didactics. So we have found this very successful. We have presented this at national forums, and this is becoming very normal in the United States in terms of teaching and education in their residency. This was the summary I wanted to present. Thank you so much for your attention.
Thank you, Dr. Anish. Please take a seat. And can I invite Dr. Fiza Gilani also to please come on the stage? So we can get, now it's going to be a Q&A session, and if we can have students to go through the rows and get some questions. In the meantime, we can get our chair, Major General Salim Ahmed Khan, to come and give his comments, please.
Bismillahirrahmanirrahim. Thank you very much, Professor Umar, Vice Chancellor, Rawalpindi Medical University, for arranging such a wonderful seminar. And I'm grateful to APPNA always. They are always forthcoming for all the educational activities and all the help they are providing to this country. Professor Naheed, Danish, Shahid Rafiq, we are collaborating with them for some time. And I had just seen Major General Imran Fazal here. Is he here? Sir, please join us over here. Ayub Raji. Major General Imran Fazal is Professor of Medicine, Army Medical College, and he is also Director General of Medicine in General Headquarters. Please join us. We had just seen two of our speakers. They have talked about two very important subjects. One was what are the different types of healthcare systems, and she elaborated, Dr. Fiza elaborated about the systems which are in different parts of the world. But it is important for our students and our healthcare providers that how we can improve our own healthcare system, in which the primary healthcare is lacking. The important thing is that we are a very sort of poor primary healthcare system, and this conference is all about improving that system and the family healthcare. She has also talked about electronic health records. So this is how the first world or the advanced world is functioning. Our students who are going to the wards, they are still dealing with the files and the papers and the investigations, and they are all the time putting pins to them, and sometimes they are lost, and sometimes the instructor is looking after them and you are still collecting them. So this is of era of paperless records for the patient, and everything is available with the system, approachable. It is beneficial for the patient himself, and it is beneficial for the organization to monitor, and it's beneficial for the physician to track his patient as well. So this is one area in which we have to progress in our country, and it is not an easy task. It needs a lot of investment, and it needs a lot of determination, but a time will come with most of our hospitals. There are still some of our hospitals who has this electronic record system. And secondly, Danish, always a very fascinating speaker, has talked about e-learning. So, अगर मैं ये बात करूं कि हमारे वक्त में और आपके वक्त में what is the biggest change हमारे स्टूडेंटशिप में और जो मेरे सामने स्टूडेंट बैठे हैं, the biggest change is that you have now the access to a worth of knowledge and worth of variety of knowledge which is web-based, and you are using internet on your mobiles, on your apps, so you have access to knowledge. मुझे याद है कि in late 80s and early 90s, I was doing my thesis for fellowship, और मुझे 2-3 articles की ज़रूरत पड़ी, तो I had one of my relative to get it from USA and then mail it, and it came with a lot of difficulty. और अभी आप देखें कि आप लाइब्रेरी में जाते हैं तो डिजिटल लाइब्रेरी भी नेट पे अवेलेबल है, HEC की लाइब्रेरी और मेडस्केप है, अप टू डेट है, whatever is there, you are just accessing it. So similarly, there are a number of online courses which are available. So this is of advantage. Wherever you are sitting, you can join a course, you can sharpen your knowledge, you can improve your professional skills, And these are all CME and CPD courses which are available online, which is very easy to access. And there are many online courses which are interactive also, and you get this lot of people who are joining these courses, and they are improving their professional knowledge. But the disadvantage of this e-learning is that if you are sitting somewhere, you are not having the thrill of the campus. एक कैंपस में रह के पढ़ना और एक ऑनलाइन कमरे में पढ़ने में बहुत फर्क है. You are away from your society, you are away from your group of friends, and secondly, you lack the communication skills sometimes. When you are in the classroom, you are interacting with the teacher, and you are interacting in small groups and in classroom groups. So this is how it has the advantages and disadvantages. But still, all our students are in an era where they can access to anything and access to knowledge. And what they say is that this knowledge and data of medical records is changing in every about 73 hours, 73 days, it is doubling. So you have to keep pace with them. So I thank once again to the organizers for inviting me, and I hand over the mic to the moderator for the further panel discussion.
Thank you, General Saab. Let me officially welcome one of our own Rawalian, Major General Imran Fazl Halal Imtiaz. He's the Director General of Medicine, Pakistan Army. He did his MBBS from Rawalpindi Medical College. We're proud to have you, sir. He held posts of Professor of Medicine in Army Medical College, Rawalpindi, Director, Acute Medical Unit in Pak Emirates Military Hospital, and Dean of Medicine, NUMS. Welcome, sir. So, next we'll move on to our panelists. We'll get some comments from them. Can I invite Professor Mustafa Kamal Pasha, please?
Assalamu alaikum to everyone. I would like to thank APPNA Merit, HEC, and definitely Rawalpindi Medical University for inviting me here, having me here. And I'm thankful for the hospitality you have extended over the last 2 days. I remember as a young doctor in 1985, I went to UK for training. And the first technology which I felt which was being used in the medical care was a bleep system. And we were very happy to have that bleep, because with that bleep, they could find the doctor immediately, even whenever required. And especially the crush team for the cardiac arrest team, they used to have a bleep with a special sound in it that you have to, and then they can even specify where you have to go and what is the patient's problem. And with that, from that period, the internet came, and then the technology started entering into the healthcare system. Now there are so many things that if we start talking about, probably weeks and days are required for that. I'm happy to inform you that in Pakistan, we are doing quite a bit now. Rather, I think I'm pretty sure that the first public university and hospital where hospital management and information system has been placed is Nishtar Medical University and Hospital. With this system, we can manage not only patients. I just want to tell you just a little bit that how do we manage. That when a patient enters the hospital, he's been given an MI system, MI number. Or we also get his ID card or national ID card number, which acts as his MI number. All the things, now Nishtar is a paper-free hospital. You need not to use papers to take history, to discharge a patient, only a little slip comes out. And if you want a record, it is connected, the system is connected to our labs, our radiology department. Just with a click, you can see all the records anywhere from the hospital, even in theaters and anywhere. And If you want to do research, the data is available. Again, we just have to access to the system. So we have developed this system and we are planning to connect this system to our GPs, and in this way we are going to help the primary care also. It's similarly as we had the system in UK also, that from the GPs, the patient, they come to the tertiary care hospitals, and with this system they can find the bed availability, the consultant's presence, and if they can be operated on it or not. There's much to say, but I know I have a short time to talk about. And coming to this e-teaching, again, this is very much in. While I was sitting there, I learned a few things on my net, and I know these students, they have got much more knowledge than we have, and I think I would love to contribute as we will proceed further, and we'll have a discussion on it. And again, I thank you all for having me here.
Thank you, Gansab. Can I invite our second panelist, Professor Masaratul Husnain Shah, please come and speak. Give us some comments, please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good morning. I'm thankful to the Vice Chancellor and faculty of Rawalpindi Medical University. APPNA doctors, they all are APPNA doctors from Pakistan in the United States, and Higher Education Commission for organizing a conference on such an important issue of healthcare in Pakistan. It's very auspicious that now the policy makers have not only felt the pulse of the healthcare system, but also taking notice of the irregularities we need to fix in due course of time. I do believe there's no single simple system of correcting or giving health care to this vast public comprising 22 crores of people in Pakistan. But as I've served for more than 30 years in healthcare, and I'm still working in educational system, I would say that the main need of this country is in healthcare is family medicine or the primary care, and it needs due importance and proper planning for service delivery. We need to create systems. As far as technology is concerned, it is mandatory to adopt technology, and I usually think that if there is no system, that's a strength. In Pakistan, the systems are not yet in place, so that is why we have this strength of putting in the most advanced systems over here. E-learning and e-health, both are very important. Telemedicine is something which is of lot of use in Pakistan. It's being practiced elsewhere, and it's being practiced in India and many other countries, but it has not been adopted in Pakistan. And as I come from a village, I understand there are many places where doctors don't go, and if we create some spokes over there for telemedicine and train some physician assistants or some clinical assistants to be posted over there, we can not only remove the quackery from those areas, but also give proper health care to our population. Another thing is the need assessment. We lack this part, and we sometimes implement the ideas without proper need assessment in our population. So I would recommend that we should organize some study or some basic framework so that we exactly know what is the need of the population in terms of health care, and then what are the probable solutions to fill the gaps which are already there. Documentation and proper use, tailored use according to our context, because we cannot implement the systems which are elsewhere in other countries being implemented. These systems need to be tailored according to our own requirement, and I'm really sorry to say that there is disconnect between teaching hospitals and basic health units and rural health centers in Pakistan. And that is because of the departments and different organizations, teaching institutions and healthcare departments of the government working not in integration or integrated system, but working on their own and without any proper dialogue between those institutions and the government departments. So I would stress that we need to talk to each other. We should have a proper need assessment from the population, and then use of technology in e-health and e-education is to be incorporated in our healthcare system. Thank you very much again for inviting me over here.
Thank you, Professor Musad. So we have about 20 minutes for Q&A. We have quite a few questions. So we'll open to Q&A now. We did a pre-conference survey before the conference, and there were some comments and questions from that survey. So we'll do that first, and I'll just give you my personal example. In Canada, in Alberta, we started EMR system in 2000. At that time, there were lots of vendors, about 17 vendors. So each clinic were having different EMR systems, and from the government, the wish was they can have one system or they can talk to each other. So we didn't have that kind of system, and they were saying, okay, within 5 years we'll have such a system where everything will be available, all physicians can see each other's medication which were prescribed or investigation which were done. So a question from that stems is, in Pakistan scenario, can we implement such kind of EHR system where all the doctors, whether it be primary care, secondary or tertiary care, can see necessary patient information, of course confidential information, their notes normally is not shared on EMR. So is it a stepwise approach we can do in Pakistan, or we can start somewhere? How can we do that?
I'll start, and then I can see if other panelists want to add. I think we're starting late in establishing electronic health record system, which is of advantage because we can learn from mistakes of the other. We have seen others try first and see what issues happen. So in the United States where I practice, the biggest challenge now is that because every hospital has electronic medical system, the patient feel naturally that when I'm coming to see you, you should be able to see what other doctors did. But hospitals' electronic systems don't talk to each other. So although they have an electronic system in another clinic, another hospital, when they come and see me, I still cannot access it. There is no cross connectivity. So the biggest work or effort going on in the United States right now is to find ways to connect the system so that they can talk to each other and information can flow. There were so many different electronic systems, each designed differently, independently, and so much money was invested, and now we're trying to fix it by creating patches. But here, I think in Pakistan, we have an opportunity because nobody has electronic system and we're just starting. From the get-go, I think government should step in and set some basic criteria and guidelines which make sure that any hospital who's adopting electronic system should adopt in a way that it can cross-connect, so that if two hospitals in the same city has electronic system, they can exchange information freely, easily, quickly, immediately. That would be my suggestion.
I think the Higher Education Commission have developed a department, and they have got a director, APPNA, which actually look after the connectivity. And with this connectivity, I think most of the hospitals and the universities, they will be online. And you can share the data, and you can look at each other, and you can discuss frequently by connecting with the satellite links. So I think this thing is being done, and I think this is the right time. We have to press towards the right direction. That's your experience, what you have seen, and with that we can learn and can move in the right direction.
Thank you. What we are talking about, the data sharing and records of the patient. In our country, we are still beginners. Some of our private sector hospitals, they are using this electronic health records, and they are sharing with within the hospital with their clinician. That's available for everybody to access also, and for the patient as well. And but still, we need to, the government and the policymakers have still to invest into it. Whenever we talk of improvement in health facilities in our system, I always say that it's an investment. You cannot improve your health without investing, and why? Without putting money into it. You can talk day till evening, but unless you have the necessary budgeting for that, it cannot improve. In our military setup, we have started the hospital information system in our military hospitals, CMHs, and all our hospitals. And it's working very well. There is a paperless environment for the outdoor and indoor patients. But still, we are in a process of connecting all our hospitals together. So anybody in Loralai or Zog can also have access with our central server with that. So I suppose within 5 years' time, we are on it, and hopefully we'll be able to do that.
Thank you. Just adding on to these, suggestions, that I suggest that there should be a national database in which all the data is to be centralized. And of course, there are some problems that, confidentiality issues and all issues that can be taken care of. Every patient, the problem what I see is that if a patient from a small place or from countryside goes to a big city, the consultant over there has got only like 10-15 minutes to see or examine him, and he does not have any access to his previous records. And in that way, that is half done, and proper diagnosis and management plan cannot be, done accordingly. So if there is a national database, any consultant have an access to the record of that patient, and then do follow-ups, the patient will be benefited in that way. That's one way. So we need to have one language across all the hospitals, and we need to incorporate the GPs working in small areas and convince them, because it is said, as Iqbal said, that आईने नौ से डरना तर्ज़े कोहन पेड़ना मंजिल यही कठिन है कौमों की जिंदगी में. So we need to change the attitude and give incentives to the primary care physicians who are working on their own, serving this humanity and these people of Pakistan. Thank you.
So thank you very much. So next question is also a little bit related, and also is directed towards Dr. Fiza Gilani. So the question is, EHR electronic health record system is very prevalent in North America. So in Pakistan, lots of doctors are afraid of this. What can be done? How can we convince them to start using EHR systems?
Actually, in USA, the Office of National Coordinator, that is the responsible entity within the federal government who controls the standards of EHRs. Any EHR, small or big, that is controlled, and it has a defined standards. And in terms of data privacy, that's a big issue there. But Office of ONC, they issues the data privacy rules, and every EMR and every agency has to follow that. And in terms of exchanging the information between different EMRs, health information exchanges are the ones which are being used there, and that is by patient permission. You can put their information in the health information exchanges, and this is state level initiatives. And you can move the information between one EMR to another one. But this is all very well controlled by ONC guidelines. So no one can do any unauthorized transfer of data without without getting the permission from patients. So it's all patient-centered and patient-controlled.
I want to add quickly to this. I think the fear of electronic health record is very, very reasonable. It will not be easy to go to electronic health system. We used to have a partial electronic system when I was a resident in University of Nebraska, 2009 and 10, and we shifted to a complete electronic health, complete paperless. There is no paper in University of Nebraska anymore. Everything is paperless. You cannot have a paper on patient anymore. And when we transitioned to that, it was a mess. Physicians were complaining. There were complaints everywhere. It was so expensive. There were technologists for the electronic health system running around, solving problems, tickets everywhere. When we transitioned, we cut down the patient visits by half. So everybody who was seeing 10 patients, let's say, in the morning, their schedule was cut down to see only 5, because we knew it would take twice as long with the new system. So yes, there are growing pains, and they happen everywhere. We're not, special in case of being better or worse. It happens even in America. It doesn't happen smoothly in America either. It was really, really painful. Second, we can make it easier by doing multi-step transitions. So as I said, we were on a partial electronic system. So there were paper charts, there were paper notes, but labs were electronic, prescription was electronic. Well, there was paper prescription initially, imaging was electronic. So we can look at doing staged transition. However, it will be far cheaper to just switch directly. More steps you add, more expensive it will be, more complicated it will be, multiple pain episodes will happen. So maybe shock therapy is the best way to go, and expect there will be 18 months or 2 years of transition. But that would be kind of a political decision or a leadership decision, because it will cost a lot of political mileage to do it, because it will be painful. It will be very painful. Pains are real, pains will happen. So either we accept it or we stay in the dark ages. There are no solutions.
No, that...
You can write, Thomas.
You can write the question. So, I just want to add to the same one from my personal experience. As Danish mentioned, it's not going to be easy. It's a painful process. When we started in Alberta, in Canada, this process in 2000, government was giving money to the clinics to go onto EMR system. They were giving money for computers, they were giving money for training, networking, even IT support. And yet, lots of doctors were hesitant to go into, they were thinking government is tracking them, they want to see their system, what's going on, if they're practicing properly or not. After a year or 2 years, when I asked them, do you want to go back to the paper system? They said, no, we don't want to go back. This is the best system. It tracks so many things. Now, after 20 years, where we are now, we have a Netcare where patients can go, doctors can go and see their prescription, radiology, labs, and everything. And now they have introduced another system, it's called Connect Care. So all the systems will be talking to each other. And last month we introduced another system, it's called Patient Portal. Patient can log in through their health number and they can see their results. That's a lab results, radiology, consult reports as well. So that's improving and patients getting benefit from that.
Can I just add one thing, please? My name is Dr. Zafar Zaidi. I represent Indus Hospital. We have been running an electronic medical record system and a paperless system since 2007. In fact, the General Sahab, what you mentioned, your software is the one that we have given to the army, which was modified for the army. It is difficult, but if the political will is there to implement it, it is not that difficult. I would agree with the speakers that once it is implemented, people who actually use it don't want to go back to the paper system.
That's right.
You're running everything. I just want to add here is that this is an opportunity in Pakistan where we can have a centralized database where the NIC, each one of us has a computerized chip in it, has enough space to store everybody's data and a lot of it. You don't have it in the United States, you don't have it in Canada, but we have it. And Nadra is very well equipped to do it. So the problem is that there's a Punjab IT board running its own system, there's another hospital doing its own. We will end up in the same mud as you guys have in US, where in a block of 1 mile in Boston, 6 hospitals don't talk to us. So I think that's one option.
Excellent.
Another thing is just to give everybody that it is very much possible, it is being done, should be done, and it is useful.
Excellent. Thank you very much. So we have just related to this topic, and then I have another question which is a little bit different, and we have only a few minutes left. So the next question is, what do we have now, right now, in Pakistan? The question was, we have a secondary level and tertiary level EMR systems. What about primary care? Can we start in primary care? Is it already existing in primary care, BHU level or Tehsil headquarter level? Any takers for this question?
I don't think so. We have got any such system at BHU level or primary care level. I was just, if you allow me, the previous question,
sure.
Because we are going through this process of that we are having this HIMS system in our medical college and university. The first and the most important thing is that we need to have computer literate people. And that's the biggest problem which we are facing. Now, thank God that these youngsters who are coming up, they are very good in computers, because they keep on playing with that. But the nurses, the paramedics, the few senior doctors, they can't do it. They still use one finger for everything, and they find it so cumbersome that if they have to write a short statement, they take it for an hour or so. So we just keep on going after them, that they have to come and they have to keep on learning. I think this is the biggest task which we have. I think if you have something which you have, how you come across it and how you manage it, that will be a help for us.
Excellent. I think there's a, Danish, you want to answer? Yeah, there is a solution for that. Like most of these EMR systems, they have templates, or you can add a dictation system to it. Even Apple has now, and there's Dragon dictation system. Very helpful. I still do one finger. So when you dictate and you have templates, that was magic.
See if you have Dr. Hina's comment, so we can also take that into consideration if you have received Dr. Hina's comment. So I want to add what Zahid was saying, sir. If once we have decided that we'll do it, and once we've decided, okay, we'll try to pay the cost we have to, there are ways to try to solve some of those problems. We had the exact same. We had the.
Oh, it's gone.
We had the exact same issue that the more older the physician was, the bigger the challenge. So the really old physician, like my partner, my mentor, Dr. Bertoni, who trained me and is my co-director, he hated it from day one. He still doesn't like it too much, although it's been 7 years now. So that is definitely a challenge that the less familiar with the technology you are, the more harder it is. But like Dr. Zahid was saying, there are ways to fix it. So I don't type anymore. I used to type, and typing was really hard. The dictation is so good, it's 99% accurate. It learns you gradually. Because we're starting new, again, we have opportunities to just learn from what mistakes other people did. So all my documentation is through dictation, and it's so fast. It's as fast as I'm speaking right now. I can actually speak faster, but I don't know if you will be able to understand that. But you can really speak really fast, and they say that you can speak 300 to 400 words a minute. And a computer can really pick it up and can dictate it. And of course, we have accents, and English is not our primary language. I have an accent, but the computers do gradually get better and better. So when I started, it was only 60% accurate, but now it's 99% accurate for me after using it for 3 years. So I never type anything. Orders, notes, emails, documents, everything is on dictation. There are many such solutions to many problems that we face, but one thing that cannot be removed is that there will always be a challenge to learn technology for people who are not familiar with it.
Excellent. Thank you. I think let's switch gears. There's a question for our Vice Chancellor. Do you see a role of online learning and its courses in Pakistan, and do you think they will be accepted in academic circles and therefore accredited by national bodies, online courses, and also you can tell us like a faculty role, overseas faculty role in this one? Pakistan.
I mean, there is a room for these online courses, and some of our universities are offering online courses. To my knowledge, there is certificates in healthcare professionals and other courses, and a few more CBD courses which are available. But these online courses have to be, at some part, should be interactive, or should be, if it is a 6 months course, then some component should be on campus, so that if it is totally online, then there is less acceptability for the accrediting bodies to register it. If it is part-time, on campus also, and part-time, most of the time online, and maybe about 2 or 3 weeks in campus with interactive all the students, then it gives more acceptability to everybody for these online courses. But I think in coming future, more of these courses would be available from the universities and from other colleges also.
So, I heard that a little bit yesterday, and I am becoming more and more aware that there is some challenge in figuring out how to add or accept online learning. For some places it's acceptable. So I've seen people do like a master's in medical education or MEd in online virtual universities, and that's okay for your promotion, and you can promote to, from a rank up or something. But it's more challenging to figure out place in more clinical practice or clinical training. So like training someone as a family physician or giving them a diploma or neurologist. So those places I think will take time, and they would probably never become completely online, but they will have to be blended in some form, that there is some online component and there is some face-to-face component. And I think it will be an evolutionary process over the next 5-10 years in figuring out what has what place, and slow time to become comfortable with the online components.
Danish, you want to comment on APPNA Merit, how they can use it?
So right now, the way we have started from APPNA Merit or APPNA side is to create informational modules that are not necessarily replacing. So the goal is not to offer degrees or offer training that replaces the current system, but the idea is that can we at least start complementing what is already going on. So let's say you are learning about neurological examination, but can we offer you some more details online and some additional component by creating a module online. So we have started a project called APPNA Academy. The website is appnaacademy.com. You can also go to appnamerit.com and learn it from there. And we will be uploading a lot of these learning modules for various different skill-based training. So like use of ultrasound, injection techniques, use of botulinum toxin injections for migraine and dystonias, neurological examination from all levels, basic and advanced, and hopefully at least start people becoming familiar with how to use these modules. And then we'll have to work with our partners locally to see how we can blend these online components into their ongoing courses and programs.
I just want to have some clarification. I mean, we would like to know that these online courses which you have just mentioned, what about the interactive portion that can these students, they could have opportunity to interact also with those teachers who are doing these online courses? Because just looking at something, listening to it, seeing to it doesn't give you the complete knowledge. So what about that component?
That's a very, very good point, and that's something that we struggle with. So if we want to create a course where we want to guide the students' learning by having interaction, by giving them feedbacks, by discussing cases with them, that's doable in the virtual environment, but then you have to have a small group. So if I'm teaching, I can only have 8 or 9 or 10 students at a time and not more than that. But then it's not scalable. I cannot teach more than 10 people at a time. So that's what our online mini fellowship is, only 10 to 12 people at a time for 1 year. So we cannot train more than that. So I get 40 or 50 applications, but I only select 9 or 10 of them. So I can teach them guided with interaction. But at the same time, someone comes to us, so there's a request from China to University of Nebraska that we want an online course on Parkinson's disease. And we say, okay, how many audience? They say we need it for 10,000. So we cannot have a guided interactive teaching for those 10,000. So there is some place for self-paced learning, uninteractive, but that's more for knowledge component, not for skill. But where the skills are involved, then you have to have an interactive component.
Okay, excellent, thank you. So there's another question, I think it's very important, like in the audience, this is most what I hear and see, lots of questions are related to the same thing. The ground reality in BHU and primary health care sites, they're so busy, so many patients. And the question is, how can we learn, how can we teach other staff how to use EMR? What can be done? Like, how should we do it? That's a panic, or that's, Dr. Gilani, you can get started. So how can, will there be a time for them to learn how government can intervene, whether there'll be third party who can come and teach and they can see their patient in the meantime?
Actually, I will say, let's take the example of cell phones. We all learn cell phones, right? Last 10 years, everyone can use, everyone can learn. So think about EMRs in the EHRs in future. The training modules provided by different hospitals to learn EHR are many times they are embedded in the system, or any hospital or any organization, private group can start up as the trainers and start doing training for different EMRs at different levels. In our hospitals, any new employee which is hired in the hospital gets through a very intensive EMR training, and that is given by our own departments. So that's what I meant when I said we need to create new departments within the organizations to train the new employees to use the EMRs. And I think just think about like EMR usage as cell phones usage in future.
So this is a really, really important question, that the burden of care on physician is so much that how do they adapt to EMRs? How do they do e-learning? How do they go for diplomas? And over the last 5 years that I've been coming to Pakistan regularly every 3 months, doing clinical practice, doing teaching clinics, doing workshops and courses, I have personally come to believe that the reason system in US works so well is because there is a concept of importance of time and realizing that things take time. So for a long time ago, US decided that there will be a length to patient visit. You can decide whatever it is. Let's say 10-minute visit or 5-minute visit, whatever. Let's say 5-minute visit, although you cannot see a patient in 5 minutes, but let's just say that. Even if you limit that to a 5-minute visit, then you must calculate how many patients can be seen in that hour or in that day, and then you must not put more patients to the physician in that day. Otherwise, nothing else will happen. If the walk-in concepts don't go away, if we always say, okay, aaj 150 aa gaye to 150 dekhenge, aaj 200 aa gaye to 200 dekhenge, the system will always stay so burdened that it cannot transition. So the first thing will be to set some ground rules. What is the minimum visit duration? What is the minimum or maximum number of patients, 4 hours, a half day or a 1 day that a physician should see? And you can start with a very small time, like 5 minutes, I said. In minimum length in US is 15 minutes from a primary care physician, and that's a follow-up, and it's a 25 or 30 minutes for a new patient. My new patient is 1 hour. So I have 1 hour block for every new patient. That means that in 4-hour clinic, a half-day clinic, I do not see more than 4 new patients. I'm not asked to see more than 4 new patients. And I'm compensated for 4 hours time for seeing just 4 patients. And that means that if someone needs to see me as a Parkinson expert, they will be given an appointment which is next available, which may be 4 months out. There was a time where we had next available appointment 9 months out. As a specialist, that's okay. In primary care, we try to not do it that much. We don't want patient to wait more than 1 week to be seen, and that does work in primary care. But if even forgetting about the time durations and lengths, the bottom line is that in principle, we'll have to agree that it takes a certain amount of time to see a patient, whatever that time is, and then in a day, there is only so many hours to see only so many patients, and there have to be some way of organizing and scheduling that burden, and then we will figure out how much more physicians we need, and how can we train these physicians, how can we incorporate EMR, and add other things. Thank you.
Thank you, Danish. But the thing is, it can hurt the pockets of family practitioners or GPs. So initially it will be hard for sure, but I think gradually you'll catch on to it. So there was lots of requests from the floor that people want to have a mic, and because such an interesting topic, as a policy for this conference, we can still collect the papers, please, and we'll answer them in due course of time. Not now, we should end this session, it's already over time. So I'll ask General Imran Fazal, please kindly come and for the closing remarks for this session. Thank you.
Assalamu alaikum. I'm rather humbled to stand here where I belong. And I'm especially thankful to Professor Umar, my dear friend, my teacher, my mentor, for letting this occasion happen. Thank you very much, sir. I'm extremely grateful to APPNA Merit and colleagues from the family physicians and the Rawalians that I am invited as over here. Let me share some very basic thoughts with all of you. You see, as a human being, we have got 5 senses. But now as the science is progressing, as there are so many advances, the success lies in having the 6th sense. And what is the 6th sense? Someone says it is e-learning or what. I would say it is the art of learning. One has to learn the art of learning and de-learning and relearning. And if someone learns this art, and as young medics, all of you can do this. Why? Because now we are having our electronic intelligence with us, our artificial intelligence with us, and it is this artificial intelligence which is going to act as our 6th sense. 1. The second thing is, although Pakistan is not a very, very wealthy country, we have our own problems. We are not a very rich country. We are a growing economy. We have got problems, but we are facing it. And we face it bravely, and we are trying to overcome it at the government sector, at the private sector, as our friend from Indus Hospital has just told, that they have got a literally paperless environment. And let me share with you that in Pakistan Army we have got 45 hospitals, and we have a hospital management system which is partially linked, and our system speaks to each other hospital. And this is how we are trying to grow, and we have reached this stage over the last decade. So it is a process of learning to which all of us are passing through, and I am sure, I am quite confident that there would be a time, maybe another 50 years, maybe 40 years, but there would be a time then we would be having this 6th learning avenue for ourselves, 6th sense, even at our BHU level. The other aspect of family medicine, how I see the family medicine, you see, although this is a primary responsibility or it is the primary care, but the name family medicine goes with our fabric. It goes with the fabric of our culture. What's the difference between the Eastern society and a Western society? To me, Eastern society is all interlinked like this. We are joined like this. So if we develop a community of medical professionals which are family physicians and who are trained family physicians, not as a simple GPs, their family physician is a specialty. And they should behave, they should think of themselves as a specialty. We are going to support them. Then there is no way we cannot have this sort of fabric in our part of the world. And what is the society like in the West? It is not interdependent, it is independent. So that's the difference. So I would say that in our fabric, the fabric of this country, the fabric of East, it's very convenient to have a good family medical services, and if we just think and plan about that. And in the end, I'm being overwhelmed by the efforts made by APPNA. As the name indicates, it is not APPNA, it is APPNA, it is ours. So I'm really thankful to the President APPNA, Professor Nahir Usmani, Professor Shahid Rafiq, and especially Dr. Danish. Danish is a wonderful person, he's a wonderful person. And I have been in contact with Danish for the last few years, and what I've always realized, he is all the time involved in some sort of learning. And he has learned this art. What I say that the sixth sense, he has learned this art. But I'm sure all of you can have this sixth sense. And the last point which I want to make is that in this country we have got a very good association of family medical practices. Our friends from Association of Family Medicine are here, and these are the people who are our torchbearers. We would support them as a community, as a nation, and with the support of APPNA, I think we can go a long way. Thank you very much.
Thank you, General Sam. So with this, we end this session.